So we're going to do a little bit of background on bipolar, and then we're going to talk about the Oruc study. I'm not going to read this to you. I'm going to let you remind yourself of it. Um, there are two types of bipolar. One of them is bipolar type 1, and that is alternating periods of mania and depression. I highlighted a significant difference here and then another significant difference here that I'll talk about in a second. But for those questions where they're like, what is it probably like for Asha to live with mania and bipolar or whatever, this is a really important thing to review. So go ahead and read for yourself these characteristics of mania, and then make sure you remember them. And then you will notice that over here under bipolar type 2, in order to get diagnosed with a hypomanic episode is a slightly less serious version of a manic episode. I should point out, remember these words, persistently elevated mood or irritable. So you can either be elevated, very energetic, or irritable. And you'll notice here that just like with the mania, you have to have 3 or more of the above symptoms, 4 if the mood is only irritable. So if you don't have the the elevated mood, you need to have 4 of them. But notice that it is a manic episode if it is sufficiently severe to cause marked impairment in social or occupational functioning or to necessitate hospitalization. We use that term, remember, ROSE. If it is a significant impairment to your relationships, your occupation, your social, or your educational, that's just a way to remember it. It is manic if it is sufficiently severe to impair that. It is hypomanic if it is not severe enough to cause marked impairment to those things or to necessitate hospitalization. So I had you read this. I think part of the confusion on Oruc is not really understanding what was the nature of the study. So we'll talk about that again. But in particular, I wanted to draw your attention to this section. I'm going to let you read this section for yourself. So there's 2 things going on simultaneously. As with most research, the larger your sample size, the better you will be able to, the more likely that you'll actually be able to identify a genetic locus or loci, a particular area of the genome that is associated with the disorder. So we want to make sure we have really large sample sizes, but at the same time, the problem with that is, and the problem that they used to have with schizophrenia, is that they're including too many people. Down here, you'll see bipolar 1 is the most severe, most reliably diagnosed, and most genetic form of bipolar, yet almost all previous genetic studies have failed to study the BP1 phenotype without clouding the picture by including BP2 and recurrent depression in the phenotype definition. So we would have a better chance of identifying the particular genes that are associated with bipolar if we focused only on bipolar 1. But by definition, when we limit our sample size to only people with bipolar 1, and specifically we need SIB pairs or SIB-ships, when we focus only on bipolar 1, that makes our sample size smaller. So that's the problem that we run into. And then also when it comes to doing genetic testing, it works much better to have people who are groups of people who have the same genetic background. Let me find where they mentioned it. No doubt a major limitation to performing studies on the most severe phenotype has been the fact that finding families with large SIB-ships who are intact and agreeable to participate has been prohibitively difficult in mainstream U.S. society. In order to achieve a certain genetic risk ratio, approximately 500 SIB pairs will be necessary to have adequate power of mapping a disease gene in an outbred population such as that of the U.S. Outbred just means that people are not, I mean, it's not inbred. People are marrying and breeding with people who have different genetic backgrounds than them. They acknowledge that in a more homogeneous population, the number of SIB pairs needed may be less. So the whole thing is we're not rigorously limiting our studies to BP1. And if we did rigorously limit our participants to BP1, we would be more likely to be able to identify the genetic genetic polymorphisms associated with it, which was the case with schizophrenia. When we more rigorously limited it to only schizophrenia and not schizotypal, then or other types of psychosis, then they were able to start to really recognize some of the genetics involved in schizophrenia. So we need to more rigorously limit it to BP1, but at the same time, we still need large samples, and we need large samples from ideally from less outbred populations or more homogeneous populations. But it's hard to find those people, and then of course to find people who are willing to take part. So that's the kind of two things that are going on. But keeping in mind that we need to make sure that the people that we are diagnosing are or that the people that we're using in our study are very definitely have bipolar, and ideally bipolar 1. Keep that in mind as we start to talk about the Oruc study. So the idea to investigate whether the genes encoding for certain serotonin receptors, 5-HT2RC, the R is for receptor if you're wondering where it came from, and serotonin transporters, 5-HTT, could be involved in susceptibility to bipolar disorder. Because we know that depression and bipolar are associated with disruptions to the serotonin, like the serotonin system, these were some places that they wanted to start by looking. Your sample, this stuff. That's why it's important, and why Oruc mentions that all the patients and the controls were of Croatian ancestry up to at least the second generation, because that homogeneity of the population can make it easier to identify those genetic differences. The control group was, I don't remember mentioning this, they were recruited amongst hospital staff and friends, and obviously they only included people who had no personal or family psychiatric history, but just a flash forward to see if you remember, one of the issues is that some of these people that were the so-called controls were still within the age range where they could develop bipolar. So if you are sorting somebody into your control group to compare them, but they actually do have the capacity to develop bipolar, they do have the genetic mutation associated with bipolar, then that's going to mess up your study too. Here's your procedure. It seems like this is the part they decided to ask about on the test question. All of these people had previously been interviewed for lifetime psychopathology by trained clinicians using clinical interviews and hospital case notes. So all of these people, they recruited them from these inpatient and outpatient hospitals. So these people had already been interviewed and had been diagnosed by trained clinicians. But then, as part of the Oruc study, they were re-interviewed by one experienced psychiatrist, that was Oruc, who used a validated Croatian translation of a measure called the Schedule for Affective Disorders and Schizophrenia. That's the SADS lifetime version. So what this does is allow clinicians to, in this case a psychiatrist, to collect information about people who have been struggling, about how the disorder has progressed through the person's life. They also, in the course of this interview, collected information about their first degree relatives who had a major affective disorder, and then confirmed the diagnosis of that first degree relative with medical records. All of those interviews were then reviewed by a second experienced senior psychiatrist, and anyone who fulfilled the research diagnostic criteria for bipolar 1 were included. They don't spell out the research diagnostic criteria. It's unclear if they had a specific research diagnostic criteria, if it's just like the general diagnostic criteria for bipolar 1, but they only included them as part of that experimental group if they met that criteria. Now, it should be becoming clear to you at this point why this process was so important, because again, if we include people in our genetic study who don't have bipolar 1, then we're going to muddy the waters, or cloud, the way they said in that article. We're going to muddy the waters, and it's going to be harder to identify if there truly is a genetic difference between people with bipolar and without, if we're not very, very clear and rigorous in our inclusion criteria. The results, of course, no significant associations were found in the overall sample. They did not find polymorphisms in the bipolar group, or we should say the bipolar group was no more likely to show genetic polymorphisms in those two target areas compared to the control group. Also, participants with family history were no more likely to show those polymorphisms compared to those who were without it. But they mentioned that serotonin is known to be sexually dimorphic. So the system develops differently between men and women. So they decided to separate the sample by gender. And it was true that female participants with patients with bipolar disorder were more likely to show those genetic polymorphisms compared to the female control group. But something I don't think we emphasized much, that difference was not significant, statistically so. So yes, there was a difference in the presence of those polymorphisms between the bipolar group and the control group, but it wasn't a statistically significant difference. So I pulled this sentence out of the study itself. I feel like I never noticed it. It seems important. According to Oruc, failure to detect a strong significant association in this study suggests that the polymorphisms investigated here play no major role in the etiology or causes or development of the disease, which is a thing to admit. Like the fact that we didn't find it here does suggest that maybe those don't play any role in the etiology of the disease. But Oruc does then say the power of our study to detect significant associations is low. He doesn't like elaborate, but the idea is presumably that the sample size is small. Remember, we talked about how we need a relatively large sample size in order to be able to in order to increase the chance that we would be able to find any association. So the power of the sample they're working with to detect a significant association is low. So this does suggest some differences, at least in the way these two genes work between males and females. And then they mention the presence of controls still within that age range is likely to be diminishing that chance. So their conclusion from the abstract was variations in 5-HTT and 5-HTR2C may be responsible for a minor increase in susceptibility for bipolar in women only. So I feel like this is what we kind of memorized as our conclusion, but it's worth adding on the idea of minor. This isn't like a definitive, this certainly is not definitive evidence. You can see the strengths and weaknesses here. Let's talk a little bit about those questions. There was never in the syllabus you should teach people what a clinical interview is. Actually that does occur, but it occurs in the next unit, health psychology, which is not required. And it's not as if this stuff that's here is actually like spelled out in the key study, but whatever, it's fine. Here's what a clinical interview is. You only needed 2 marks. It is face-to-face. I think you can conduct a clinical interview via, I think doctors regularly do conduct a clinical interview via like Zoom, or now that thanks to COVID and like the expansion of telemedicine, like I can't imagine that a telehealth appointment that I have with my doctor that has a camera on doesn't qualify as a clinical interview, but whatever. It's face-to-face. It's between some kind of medical practitioner and a person or patient. So notice here that you had to say that in order to get 2 marks. Like you need 2 things, but one of them has to be this. In this case, it was between a clinical psychiatrist, but if the context here were a doctor, if the context here were a psychologist, but to be a clinical interview, it's between a medical practitioner and a person or patient. Again, this whole like verbal, nonverbal, a lot of this stuff really comes up in the health psych unit, which I thought about teaching. That's why I know. There's a verbal and nonverbal exchange. So these interviews are important because not only is the doctor talking to you and asking questions, but they're also able to see you and to pick up on your nonverbal communication. It is a medical setting. That's what makes it a clinical interview. And it is designed to diagnose symptoms, prescribe, or assess treatment. This you should have been able to get. Like if you just needed to figure out what a clinical interview was and I had never taught you, I would have known this mark and this mark just from being alive. So you can certainly commit that one to memory. It's interesting because that's not really this is the one that was what the clinical interviews were used for in Oruc. So one reason why they specifically did the interviews, these patients had already been previously assessed. So these are people who had been diagnosed already with bipolar 1, but the point of the interview that Oruc did was to confirm that diagnosis. Because again, if we don't have strict, rigorous criteria for inclusion in our DNA study, we're not going to get any results that we're looking for. A lot of you got this to ask about having a first-degree relative with a history of major affective disorder. Some of you got this confused with Grant and said it was about whether or not they had a family history of alcoholism or gambling. Different study. So here specifically was to ask about those relatives who had a history of a major affective disorder. Remember, an affective disorder is a mood disorder, so that would also include depression or recurrent depressive episodes. I didn't expect you to remember they took the SADS-L, but it is a psychometric test. Remember, a psychometric test, here's a definition of psychometrics. The branch of psychology where we are quantifying and measuring mental attributes, behavior, performance, and the like. In this case, we're talking about the quantification and measurement of disorders. Most of these, the BDI, the GAD-7, most of those that you're memorizing are psychometrics. So the point of the interview was to administer the SADS-L in order to assess the patient and further confirm their diagnosis of bipolar. So to the question of why did they have the interviews reviewed by a second psychiatrist, one effect that could have been if they had not been, most of you tried to, and shout out to you for trying to answer, you tried to answer in some way with like researcher bias, but they're looking for something very specific here. If someone slipped through the cracks and got into the study that did not belong in the study, that could make the data invalid. If the first psychiatrist made an error when diagnosing the participant with bipolar 1 or in checking the results of the SADS-L, if like they like screwed up the math or something and they were like, "Oh, yep, that person belongs in here," it would make the data invalid, and then we would have the issue of not being able to find that significant association. This is not as clear to me. Like, the participant may not be suitable for the study. That would get you a mark like they shouldn't have made it in. But it's unclear to me how it would be bad for the person if they participated. Like, it's unclear to me how it would like harm the person to have some blood drawn to be part of this study. It's unclear to me how there might be ethical guidelines broken. This feels like it's a little more generic. So like, for example, if we think back to like Freeman, like they deliberately wanted non-clinical patients, non-clinical, I should say, people. So like if you had let someone with schizophrenia slip through the cracks and then had them go in and they were like traumatized by the library scene, by the people laughing, I could see that. But I don't really see how this first one is like a good answer related to Oruc, but whatever. This is the one that you certainly need to be aware of. Like, yeah, the second psychiatrist needed to check the work because again, it is so important that we are rigorously diagnosing people with bipolar type 1 or like confirming bipolar type 1 diagnoses so that we can have meaningful data. One strength and one weakness of a clinical interview as used in this study, you can see here, it was used to confirm the individual circumstances. The patient knows their family relationships. The patient has to complete the psychometric assessment test. Most of you were like, they got more detailed information from the patient. But if you weren't very, very specific about like the patient could provide details about their family history, or the patient could provide details about their bipolar in particular, if you weren't that specific, I couldn't award you a point. But the key point here is, of course, that they are clarifying their suitability for the study, making sure that they belong. The weaknesses, I don't really see how these are. Like, the patient may use vague terms to describe their condition and be unable to clearly explain what the practitioner needs to know or understand what the study is about. But like, the practitioner is a clinical in this case is a psychiatrist, so I mean, how else are you going to diagnose it? Like, it's unclear to me. Like, how is this a weakness of a clinical interview? Is there a better way to, like, without, other than what the patient tells you? Like, yes, it's true. The patient is unlikely to know what a transporter gene is, but why does it matter if the patient knows what a transporter gene is? That's not the point. The patient may not understand the medical jargon that's used, but like, again, they're not asking about transporter genes in the SADS-L, which is the psychometric that the patients took. So I don't really see how this is a good answer. I don't. Many of you said something like any issue with an interview is like the patient may may not be completely honest about their symptoms because they don't want to be diagnosed or whatever it is. That seems like a better answer to me, and 7 times out of 10, that is what they're looking for when they're asking about any kind of self-report. So keep it up with that. But yeah, there's a little bit more about Oruc. It's like it's 4 pages if you remember, and like one whole page is about like what exactly they did with the blood. And if that's what they ask on the test, skip it. I can't imagine that they expect you to have like a really detailed understanding of DNA testing, although at least now you have a better understanding of what it takes to actually get results. The answer is a large sample, specifically with sibling pairs, but also a more homogeneous population within that. Hope that helps.